Thank you, Mr. Chairman. My work today is on the value of serum proneurotensin as a predictor of cardiovascular risk in NAFLD patient. This is my disclosure. Why cardiovascular disease with NAFLD? As cardiovascular disease and non-hepatic malignancy are the most common causes of mortality in patients with NAFLD without advanced fibrosis, while death from liver disease predominates in patients with advanced fibrosis. Also, cardiovascular disease and NAFLD has common risk factors. All we know is the pathophysiology and etiology and the disease modifiers in NAFLD. And in spite that liver biopsy is the gold standard for the diagnosis of NAFLD, a presumptive diagnosis can be made in many patients based on their history, laboratory test, imaging, as well as ruling out other causes. Multiple serologic markers are used for the diagnosis, non-invasive test, imaging, lifestyle modification, including diet, exercise, weight loss remains the main treatment option. Pioglitazone and GLP-1 may be beneficial in diabetic patients. What is proneurotensin? Neurotensin is an endogenous tridecapeptide neurotransmitter that was found in mammalian brain and gut. It was discovered in 1973 in the bovine hypothalamus. It was so named because of its location in the brain and its hypotensive effect. Then it was isolated also from the GI, from the neuroendocrine end cells of the jejunum and ileum. Proneurotensin is more stable than neurotensin in the bloodstream and is produced in equimolar level and share the same biological function, so measuring proneurotensin is more accurate to determine circulating neurotensin content. Studies detected that neurotensin elevated level in diabetic, cardiovascular disease patients, and NASH patients. Increased plasma level of proneurotensin was shown to diagnose NAFLD and indicate severe disease. The Framingham Heart Study of Spring cohort demonstrated that increased plasma level of proneurotensin was associated with higher major cardiovascular events, and this association was independent of other classic cardiovascular risk factors. So the aim of our work is to study the value of serum proneurotensin in the diagnosis of NAFLD and to study the association of serum proneurotensin with the cardiovascular risk in NAFLD patients. We studied 180 patients divided into 3 equal groups: NAFLD patient without evidence of cardiovascular disease, 60 patients; NAFLD with cardiovascular disease, either coronary artery disease, ischemic heart disease, or peripheral arterial disease; and 60 control healthy individuals. These are the exclusion criteria. We excluded patients with a known cause of their liver disease, excluded diabetic patients, and those with body mass index more than 35. We done general examination, body mass index, pelvic abdominal ultrasound, liver function test, FIB-4 and NAFLD fibrosis score was evaluated, Framingham risk score calculated for all patients without cardiovascular disease, serum proneurotensin was developed. Our results, this is the first group, which is NAFLD without evidence of cardiovascular disease. The proneurotensin level was 180, while those with evidence of cardiovascular disease has very higher level, 423 nanogram, and the control group much lower, 20 nanogram. Comparing the proneurotensin level among the different NAFLD group, the control group has the lowest level when compared to those with NAFLD, and it is much higher in NAFLD with cardiovascular disease compared to NAFLD only. And also the correlation of proneurotensin with the NAFLD fibrosis score, it is highly correlated with a significant p-value. Also comparing the proneurotensin in those who have no cardiovascular disease, that is the NAFLD group without cardiovascular disease, and the control group, and calculating the Framingham risk score, those with a low risk score has a low level of the proneurotensin, while those in the intermediate and high risk have higher level, and the level is correlated with the Framingham risk score. And the ROC curve for the prediction of NAFLD is about 0.86 at a level more than 24.5 with a modest sensitivity of 64 and a specificity about 96.6, while the ROC curve for predicting the cardiovascular risk, it is about 0.85 at a level more than 28.5 with a sensitivity 83 and specificity 78. So to conclude, the serum proneurotensin is significantly higher in NAFLD patient than the general population. It is significantly higher in NAFLD patient with established cardiovascular disease, and in NAFLD patient without cardiovascular disease, it predicts those with high Framingham risk score category. And serum proneurotensin can predict NAFLD with excellent specificity but modest sensitivity. As a relatively new marker, further research may be required to validate the cutoff values that best correlate with the clinical data, especially NAFLD and cardiovascular disease. And thank you.
Thank you very much. So, questions, please? I can maybe start with one. So, as you probably know, there's a new nomenclature for NAFLD.
Yes, MASLD.
From major liver associations around the world, including EASL. And in fact, it's curious that one of the things that changes is the definition of MASLD as having at least one cardiometabolic risk factor. And it's interesting that you study this cardiovascular risk. I saw that you still included as an exclusion factor patients.
Diabetic.
And also
and the body mass index more than 35, yes.
On alcohol intake as well. So I'm just wondering if you are curious or planning to do a reanalysis of the data.
Yes, and using more FibroScan, because we started this study 4 years ago. We have no FibroScan yet at that time. So we will continue using FibroScan, and we also have the availability of elastography, MR elastography, and the proton density fat fraction, and I will plan to do this as a follow-up in this patient.
Okay.
Maybe I missed it, but how was the diagnosis of NAFLD done?
What?
The diagnosis of NAFLD was not clear to me.
Yes, it is based mainly on
Ultrasound?
yes, ultrasound. And this, we stage the patient according to the FIB-4 NAFLD fibrosis score, because as I said, FibroScan was not available at that time, but it is now.
So when you shown that there was a relationship, did you perform multivariate analysis? Because you shown many tables, but very quickly, so it was difficult to figure out what were the difference between the populations.
It is similar between the NAFLD group as well as the control group regarding the body mass index, regarding the age, the sex distribution.
So everything was very similar. The only difference was what you studied. Is that right?
Yeah.
Okay. Okay. Thank you.
Okay, thank you.
Any other?